Hi, welcome to the Sober Spill. This is Jana Wu, and today I am very excited to have Dr. Lipi Roy with us. Dr. Roy is an internal medicine physician and addiction medicine expert. She's also an international speaker, media personality, entrepreneur, and host of the YouTube series Health, Humor, and Harmony. Having trained doctors, judges, journalists, and executives, Dr. Roy rose to the challenge of serving on the front lines during the pandemic as the medical director of COVID isolation in quarantine sites for Housing Works in New York City. Dr. Roy currently treats patients with opiate use disorder at Greenwich House Center for Healing. As an MSNBC and NBC medical contributor, Dr. Roy made over 350 live appearances discussing COVID-19. Dr. Roy's work spans academia, clinical medicine, social and criminal justice, public speaking, media, and entertainment. As the former chief of addiction medicine for Rikers Island, Dr. Roy oversaw substance use treatment and recovery services at the nation's second largest jail complex. Dr. Roy also serves as a clinical assistant professor at Albert Einstein College of Medicine. Previously, Dr. Roy served as a primary care doctor to Boston's unhoused population, among whom the leading cause of death was drug overdose. She also served as an attending physician at Massachusetts General Hospital and as faculty at Harvard Medical School. Dr. Roy completed her medical and master's in public health degrees at Tulane University, followed by a residency training in internal medicine at Duke University Medical Center. Dr. Roy's mission is to educate and empower the public to make healthy decisions. As a former Forbes contributor who's interviewed medical experts, media icons like Katie Couric, and celebrities like Mary J. Blige and Ice-T, Dr. Roy is one of the world's trusted experts on communication. She has appeared on multiple media outlets, including CNN, News Nation, CBS, has been featured in the New York Times, Boston Globe, Wall Street Journal, and she is here today on the Sober Spill. You can follow Dr. Roy on Twitter, X, Instagram, TikTok, and CETA Med, and her YouTube channel.
Welcome to the Sober Spill podcast. I'm your host, Isabel. On this podcast, we have real conversations with people in recovery, their families, and organizations that pertain to this field. Today, I'm here with the host of the clinical side of our podcast, Jana Wu.
Thank you, Isabel. My guests will discuss best clinical practices, new emerging trends in substance use and mental health disorders, and how we can best take care of ourselves and our loved ones in recovery.
See you every Thursday.
And come spill with us soon. All right. Welcome to the Sober Spill. Today, we are so honored and excited to get to talk to addiction psychiatrist, Dr. Lipi Roy. As you heard, Dr. Roy has an extraordinary career. I have loved following you and following your path, and we are so excited that you took the time to travel up here. She is live in Canaan today, Canaan, Connecticut, Northwest Corner. So thank you for leaving the city to come visit us today and squeezing us in between your international travels.
I am delighted and honored to be here. I should say I'm an addiction medicine doctor, not addiction psychiatrist, but I do love addiction psychiatrists. We work very closely together. So thank you so much, Jana, for having me. I am so honored to be here.
Thank you. And thank you for that clarification. Would you mind actually explaining the difference to our listeners and to me between addiction psychiatry and addiction medicine?
Yeah, and I'm not at all surprised that that you thought that I was, because most of the folks or specialists that are in the addiction field were and still are addiction psychiatrists. We're trying to expand the scope of addiction experts and addiction clinicians and medical providers so that they come from all types of disciplines. In my case, I did residency training after medical school in internal medicine, and then I served as a primary care doctor to Boston's homeless population for several years, and then I became board certified in addiction medicine. But people can choose multiple different routes to get into the field of addiction medicine. You go through from family medicine, pediatrics, again traditionally psychiatry, but also internal medicine, OB-GYN. So we're just trying to increase the pipeline of people who are trained in addiction medicine.
Thank you so much for explaining that to us. And I think that's one of my favorite things about listening to you is you have this incredible skill of explaining very complex topics. You know, as we noted, you were incredible during the COVID-19 pandemic of it being able to explain things without, for lack of a better term, like dumbing it down. Yeah. Really finding ways, though, to take complex medical situation and concepts. How can you share more about that? How you got into this? Especially the public part.
Yeah. So well, Thank you for that compliment. I take that very seriously. I think it's a real privilege to be in the field of medicine and healthcare, and specifically to be a doctor. It's a privilege that comes with responsibility. And part of that responsibility is to be able to, explain to patients what's going on. Patients come in, they're nervous, they're scared, they're uncertain, they're frustrated, they're angry. And it's really important that they know that they are not alone, that we are in this together. Whether that diagnosis be lupus, a thyroid problem, colon cancer, a cocaine addiction. It's important as a medical professional to be able to communicate with empathy and with accuracy. And so, and then when I got into media, particularly doing live on air appearances, I always thought, nobody likes to be treated like they're dumb or they're small or they're insignificant. I'm no different. I want to be treated like an equal. And but the truth is that we all have gaps in our knowledge. Like I can't do plumbing. I can't do a lot of things actually. But nobody wants to be patronized or spoken to in a way that's condescending. And so I work really hard and try to, first of all, understand things myself, and then to be able to explain it in a way that makes sense. So I work hard at that. It's both an art and a skill. And that expression, practice makes perfect. So I try to think of things like when I explain things to either my patients or to the public, the general public, I think, well, how can I explain things in a way that my mom will understand? My brother, they're not medically trained, but they're smart people who care about their health. So that's the mindset or the perspective that I typically use.
Thank you for that. How would you describe addiction to maybe a family member, someone that's going through it? How would you describe it?
Yeah, I'm so glad you asked me that, Jana. So, I'll be very blunt. First of all, while I'm introduced nowadays as an addiction expert, I'll be very blunt. I never learned about addiction during medical school, during residency training. I took care of patients with addiction, but I never formally learned about it the way I learned about heart failure and stroke and diabetes. So the way I explain it now is I remind people that addiction is a chronic health problem. It's a chronic condition or disease of the brain. It is not a sign of moral weakness or failure. And unfortunately, most of society all over the world still views addiction or people with addiction as morally weak. They are failures. They just gotta, and you've heard these expressions, Jen, I'm sure, like, oh, you just have to buck up. You just have to be strong, right?
Just stop.
Just stop. Right?
Yeah.
Trust me, if my patients could just stop, they would, right? But think about it. We don't use that kind of language with people with heart failure or with high blood pressure or with kidney disease or ovarian cancer. We don't ever say to somebody with leukemia, oh, you just gotta get your act together. You would never say that, right? Because I think we still don't really perceive of somebody who's constantly drinking, who's constantly going in and out of jails and emergency departments, as we think of it as a personal choice, and it's not. And so that's how I would explain it, that addiction is a chronic, relapsing, remitting disease of the brain. But the good news is that most people with addiction, once connected to the appropriate treatment and recovery services, get better. That's the message I think that we need to convey to people.
Absolutely. How have you seen the field of addictions change during your time of practice? You've been through some things, Hurricane Katrina, you were living in New Orleans. Yes. Obviously COVID, you were living in New York City. How have you seen it change?
Well, I've been privileged to be working in the addiction field for about 12, 13 years. I have colleagues who've worked in the space for 20, 30 years, 20, 30 years longer than I have. So, but in the short time that I've been in the field, I must say, I've certainly seen, I think, a lot of positive changes. More medical schools, nursing schools are teaching future healthcare professionals about addiction. So that's a great change in the right direction. I think there's more of a move towards evidence-based practice. Well, what do I mean by that? And we'll talk more about that, but including medications for which we have good data and science to support, using medications to treat people, let's say, opiate addiction, alcohol addiction, or alcohol use disorder. And we're seeing more of a move towards harm reduction, meeting people where they are, not just leaving them there, but guiding them through with empathy and with evidence. So those are some real positives. That said, I think we still have a long way to go. And so that's why I appreciate conversations like this, where we can bring in people like your listeners so that they can get engaged and ask the right questions and go to the right resources for help.
You're absolutely right. It takes a combination of factors, and we have been lucky in the past few decades to see new advancements. I know we talked a little bit the other day, and I would love to hear some more of your perspective on MATs, or Medicaid-Assisted Treatment.
Yeah. When I was coming up in the field, that's how it was explained to me, MAT, medication-assisted treatment. But over time, now that I've spent so much time in learning the data, learning about what's effective, what's not effective, part of it is also just language and the importance of using non-stigmatizing and accurate language. And part of that includes medications. So in the addiction field, we're trying to move away from MAT as medication-assisted treatment and instead say medication for addiction treatment. So what's the reason for that? Because we know that medications such as methadone, buprenorphine, commercially known as Suboxone, naltrexone, these are medications that are treatment. They are not assisting counseling or assisting previously, psychotherapy or counseling and therapy, which are all effective, but medications are just as effective as treatments, if not sometimes more. So that's why that language matters. And frankly, most people with addiction for which medications are clinically effective and clinically warranted, they are still not getting these medications, Jana. And when I think about, say, my patients with leukemia or lung cancer, I can assure you I don't know about most, but the recommendation is for them to get chemotherapy, surgery, radiation therapy, other nutrition referrals. There's a clear algorithm, and most people with cancer, the treatment path is clear. But with addiction, still, they're not getting the evidence-based treatment they need and deserve.
Yeah, thank you for that distinction. So medicated
Medications for addiction treatment.
For addiction treatment.
Yes.
That's a really incredible,
yes,
I think, distinction, because you're absolutely right. It sure shifts the way we think about it.
And words matter.
Words matter very much, and it changes our brain and our neural patterning to see it a different way.
Yes.
So seeing these medications for addiction treatment to help someone with a chronic health condition get better. I mean, I've seen some of my clients have told me with certain medications, their cravings have gotten down to zero, which is so powerful, so they can make the behavioral changes that they want to make in their life to maintain long-term sobriety.
Yes.
But we all need help in different ways sometimes, and there still sometimes is, I think, going back to the bucket up, that internalized, I should be able to do this. With enough social support, I should be able to do this. Other people can do it. I should. And I've seen it be highly effective sometimes for people to take some help, whether it's long-term or short-term.
Can I tell you a story that I tell almost all of my patients? As you pointed out, I work part-time at an opioid treatment program, OTP, or a methadone clinic.
Can you say, what is it called again? Give us the...
Oh, yes, OTP. Opioid treatment program, or also known as methadone clinic. We move away from calling it methadone clinic, but because we provide other services too. Right? So the only criteria to come to our program is that you have to have a diagnosis of OUD, opioid use disorder, or opiate addiction. However, we can treat you with primarily it's methadone, but we also prescribe a buprenorphine, commercially known as Suboxone, which is a daily film, but also the monthly injection Sublocade and Brixadi. But these are all buprenorphine formulations. But I tell my patients, look, and we adjust the doses, medication, so they can reach a blocking dose. But I remind my patients that, look, as effective as methadone and buprenorphine, these medications for addiction treatment are, it's only a small part of your overall recovery. So once they leave my clinic, I have no control, right? So I remind them, and this is why I say, when you walked in, I asked you, where are you working? Where are you living? What was your support system? Because all of these aspects of their life are key in terms of their overall recovery. Yes, the medications are important, but so are all these other aspects of leading a normal and healthy life.
That's very interesting. So as an internal medicine doctor, how many other providers do you think have that systemic look of seeing their person in
Holistic.
yes, in a whole system of their supports,
Well,
family, their work?
unfortunately, so if you just look at, say, internal medicine doctors, of which there are many, I think the majority are internal medicine trained, and then they subspecialize. Again, many are family medicine, but in primary care, again, we as a system, a healthcare system, don't do a good enough job in integrating addiction care and mental illness with general medical care. We need to do a better job. And we need to do a better job, as I mentioned earlier, in training medical students and residents in addiction during their training years so that they are familiar with addiction being a chronic disease and chronic and treatable disease. So the long way of answering your question is that not enough doctors are trained in addiction, and they most certainly don't really perceive it in the holistic way that they probably should. And I don't think, frankly, the addiction specialists are seeing it as holistically as they maybe could. Again, I don't want to speak for every addiction doctor out there, but we can all, myself included, I can always do better, and I'm always trying to learn and do better.
I know that's one of your passions too. We coming back to like teaching, advocacy. You worked with judges, other medical providers, medical schools, and training providers how to see addiction differently and to destigmatize it.
Yes.
What would you like to say to people that are studying medicine now? What would you want to say, or what would you want to say to you?
Well, first of all, anyone that's studying in the field of medicine, I mean, it's a tremendous privilege. It really is to have the opportunity to listen to another person and help them in such a meaningful way. Sure, the extremes of what we do is it's truly life or death. Unfortunately, in our clinic, we see people overdosing, but we do a very good job because we are trained in taking care of people that are at risk or who are actively overdosing. So unfortunately, it can be life or death. But honestly, even the smallest changes, what may seem small to you or me, or to like a medical student or an intern, I remind them, know what you're saying and doing, even if you're just listening to them and creating a safe space for your patient to speak in a way where they're being vulnerable and honest. Because most people, because people with addiction, they've been treated so poorly, so badly by our very broken healthcare system and law enforcement, other places of authority. That needs to change. So if you, as a trainee, a young doctor, student, can create a space where you're listening with empathy, non-judgment, and with compassion, just the listening is critical. And that's not nothing at all. And then if you're able to provide services, referrals, prescribe medications, therapy, refer them to a peer, a recovery coach, a case manager, there's a whole team of people, nutritionists, housing. I mean, all of these different services, which, by the way, fall under harm reduction, things that reduce their risk for wanting to use. Because most people who develop an addiction, it's not all, but most, they're self-medicating their pain and suffering. So their emotional, physical, spiritual, psychological pain and suffering. So that's one of the messages I would say. Consider, obviously I'm biased, consider addiction medicine, addiction psychiatry, but do what you're passionate about. And once you find a line of work that you're passionate about, it doesn't really become work, it's just really joyful.
I was just going to say that I see so much light in you, and you've held some very hard jobs. I mean, you worked at Rikers Island, and that's very heavy. You worked with homeless population or unhoused populations, New York City, Boston, all over. How do you keep your light when you see such, huge societal inequities and trauma and sadness? How do you keep that human perspective with your clients?
Yeah, it's not easy, but can I tell you something, Jana? I am so lucky to have worked in these spaces. It happened really by happenstance. I accepted an offer to work for a small community health center in Boston. I got to work with the unhoused population. I learned so much, and this idea, like all these preconceived notions that many people have, but certainly myself. They're homeless. They're begging for money. They're just lazy. They just need to get a job. It's so grossly inaccurate. And so I have learned so much from working with men and women who are struggling with or experiencing homelessness, people who are in and out of jails. Rikers Island, one of the most stressful jobs I'd ever had. But let me tell you, I learned so much about our correctional landscape. There's a lot of reform that needs to happen, but there's also a lot of good people that are doing really good work. A lot of corrections officers, a lot of counselors, a lot of staff, case managers, leadership. So there's a lot of good people. We just need a lot of compassionate, patient, caring people working in those spaces. But I also learned that people that are experiencing homelessness, incarceration, all God, such a high percentage of them have been experienced a trauma background. They've been traumatized in childhood, adolescence, as adults, and they are self-medicating that pain and trauma with drugs, with behavioral addictions, the in and out of jails, prisons. Many of them have a trauma history. So, but I think we just need to all work together in a very intersectional way. Housing departments, education departments, elected officials, healthcare system, we all need to work in a very interdisciplinary way and learn from one another. Sure, those judges, they didn't know about methadone, but I also knew very little about the legal system. So they are training, we are all working together, and I think we need to do much, much more of that.
Yeah, that's very interesting too, that you had that opportunity. So to explain a little bit that background, you were actually training New York state judges?
So when I worked at Rikers, the Rikers job inadvertently opened up my speaking career because I was asked to train judges at the annual New York State Drug Treatment Court Professionals meeting. It was in Saratoga Springs in New York State, and I was so nervous. I'm not gonna lie, so nervous speaking before 200 judges and court professionals. So at the time, as a Canadian citizen, I thought, oh my God, they can deport me. All these things, but it ended up being such a wonderful, beautiful experience. I am still very close friends. I could call up several of these judges. Never a bad thing to know some judges, but it was such a great experience because I had in turn learned so much about them, the great work that many of them are doing. Judge Marsha Hirsch, for instance, she's now retired, but for years, 20 years, I think she started or was working in the Queen's Mental Health Court. She also worked in the Queen's Veterans Court. Unbelievable work, but so many people are doing, but they need help. They have gaps in their knowledge. Judges they went to law school, not medical school.
That's
right.
huge, yeah.
So working together. Training them on opioid addiction and what that really looks like. The fact that methadone, it's a very effective medication. But unfortunately, there are judges that think, oh, that's too high a dose. And then they stop them. Judges have that authority, but they don't have that training. But meanwhile, these patients are then really struggling in severe withdrawal. And so that the whole idea is here to work together. And that Rikers experience has then opened up. It turns out that a lot of the country wants to know the behind the scenes at Rikers. And so I think word of mouth got out that here I am, this Dr. Lipi Roy person. She's an actual trained physician, trained specifically in addiction, worked at Rikers, worked in homeless shelters, worked at a Harvard Medical School. So all those things I think added to certain credibility. But I think my experiences working in these unique clinical settings, most doctors don't work in homeless shelters, and they certainly don't work in the most notorious jail complex in the country. And then again, later on, my media training and media experience helped me just become, I think, a better speaker and teacher. And again, as I said, I'm always learning as well. And I think that's what hopefully is making me even better at what I do, both clinically and in the public health world and media.
Well, I think a lot of what I believe people are drawn to is your passion. You are so authentic and you care. You really want people to live their best lives. You want people to be well. I feel that. I mean, looking at, we had an adventure, this morning. Yes. We had a great car ride up to Canaan, and
you did.
Hearing about your love of adventure, you born and raised in Toronto, you've lived all over the United States of America, and obviously we talked about your diverse career.
you are so passionate about wellness, and you and I know we're both very energetic, and we talked a lot about how do we live our passions but avoid burnout? Because this field, we can care too much. And it doesn't just have to be the helping professions. I find a lot of people that struggle with addictions are extremely passionate. So when they're going for something, they are going for it. So I don't know, can you share a bit about that?
Oh my God, this is one of my favorite topics. It is. You use that B word, burnout. It is unfortunately so common, and now post COVID, it's actually it's getting worse actually, and more people I think are openly talking about it, particularly like when it's a high achieving folks like you, Jana, me, like and it disproportionately affects women, particularly women in healthcare. We have, again, none of this is Lippy's opinion. Data clearly shows that women who are both working full time and they are carrying the disproportionate burden of domestic duties as well. That's just statistically, it's far more women that do that. And, women are taught, again, girls and boys are socialized differently. I think girls at a very young age are taught to care for people, to be caring, to be nurturing. I don't think boys are any less better at that. Mm-hmm. They're just trained or socialized to be the breadwinner, to be tough and strong. But I think that needs to change. But as a result of that early socialization, girls could then go on to whatever the career is. I'll speak more of the profession I know best in healthcare and medicine. You see a disproportionate number of women in healthcare, especially women physicians, that burn out. Higher rates of loneliness, depression, high rates of suicide. So we need to address that. I'll speak personally. During the pandemic, we talked about how I worked 3 clinical jobs. I worked 2 media jobs, and I was doing virtual speaking consulting. A year and a half at that unsustainable pace, I completely burned out. And so by July, summer of 2021, I had to make certain decisions, or else I would not be here today with you. And so I made the decision to work part-time clinically. I went to my boss, the then CMO of Housing Works, and I said I need to work part-time clinically, fully expecting to find another job. And she said, actually, Lippy, I need another medical director for this other contract, and it's part-time. So I made that decision. Mm-hmm. I also learned to just say no. And no is a full sentence. Because again, especially as women, we take on so much more than we should. And so I learned to say no to opportunities, to requests, and because I just, again, the B word of the one way to combat the B word of burnout is another B word, and that's boundaries. Setting boundaries, saying no, making time for yourself, creating safe spaces, doing things that you enjoy, resting, napping, sleep. So you asked about burnout, what I do. So now in almost all of my presentations, I always start off with my pandemic story, and then I end with tips and tools that I find effective for self-care. And part of it is getting good, like 7-8 hours of sleep almost every night. And if you can't, ask yourself, why not? What are the barriers? Mindful practice. I meditate every morning, 20 minutes. I do yoga once a week. I have a gratitude journal, prayer every night. Exercise. You don't have to run a marathon, even 20 minutes every day of brisk walking, or 30 minutes 5 times a week. It releases the endorphins, the happy hormones, makes you mentally and physically better. Doing things you enjoy. I like going to the museum. I like going for walks. I love cooking and baking and going out, meeting friends, doing things you enjoy. And then last but not least is nutrition. You don't have to eat 3 big meals, but even 4 or 5 small meals throughout the day. Balance, fruits, vegetables, lean proteins. I'm Indian, so I like spices and flavor. So, those are some of the, and I know it sounds like common sense, but I remember an attending telling me when I was a medical student, common sense is just not that common. It's true. And we as high achieving people, as women, we need those reminders. And then the other thing I might have forgotten is a good support system. Just this perhaps the most important, especially as high achieving, smart women, and as professionals, medical professionals, we feel we're shaped to ask for help. There is no shame in asking for help. And perhaps might be one of the most important, recognizing when you just need help, you need to delegate, and that's totally okay.
Hi everyone, Pat McCarthy here. If you're a parent, spouse, sibling, or anyone whose life has been touched by a loved one's substance use, Mountainside's Foundation program can help. This virtual workshop provides personalized, therapist-led support, offering real tools to navigate your family's healing journey. Find out more at admissions@mountainside.com.
I'm glad you brought that up. I mean, I think especially for medical professionals, that healthcare providers have a very difficult time asking for mental health and addiction treatment.
Absolutely. Absolutely. And unfortunately, I mean, I'll speak for my profession as doctors. Doctors have, doctor couples have higher rates of divorce than non-doctor. A lot of reasons for that. Doctors have the highest rates of burnout amongst professions, and one of the, if not now, the highest rates of suicide. I mean, we are really struggling. We really are. But the good news is that we are now becoming more open. I'm working closely with PHPs, physician health programs and professional health programs. Every state has a PHP, and I just had a meeting last week with the Federation of State PHPs, and they are actively looking at burnout prevention and treatment and addiction, substance use programs, mental health programs, wellness programs. They're really trying to target the care of the individual healthcare provider and also the systems that are toxic, that make it hard for us. Because it's not, and I hate this idea like, oh, as a doctor, you need to be more resilient. No. We are already resilient. Doctors, nurses, therapists, we are all very resilient people. We are just working, many of us, not all, in environments that are toxic. And unfortunately, the U.S. healthcare system can be a lot better.
Yes.
And so again, it's a privilege to do what I do, but there's certainly areas for improvement.
I'm glad you brought that up. We actually have a whole healthcare professional track just for those that are in healthcare that need some help and that are able to take that time away and work and be with other healthcare professionals that are also struggling. And then we have a specialized curriculum for them and specialized group that allow them to talk about some of the complexities in the different circumstances of being a provider and having a struggle. So I'm really glad we're talking about it out loud. I mean, this is part of breaking the stigma, is acknowledging it.
Yeah.
There are so many different places we can go because, again, the breadth of your work is incredible. When I look at the work you've done for women, and I want to talk about that and your book, definitely. And I want to talk about, too, the future of medicine, too. So let's start with women and your book. Can you share a bit about what is going on?
Yes, I'm so glad that I'm so excited to talk to you about this, Jana. So I am co-authoring a book with Hillary Phelps.
And Michael Phelps?
Yes, that Phelps. Yes, Hillary is the older sister of Olympic champion Michael Phelps. Hillary is an elite swimmer in her own right. The former Division I. She's incredible, such an athlete. But she's also been very open about her journey with alcoholism and recovery, and she has her own The Right Room podcast. She does amazing work in this space, and for women's overall health and wellness in a very holistic manner. And so Hillary and I are very excited to be working together, co-authoring a book on women and addiction, and we are just really excited. The proposal's already done, pitched to publishers. We're about to sign a contract. More of that to come out, but we are hoping that the book will come out early next year. So keep an eye out. I will definitely be telling you about it. But we're going to be talking about, Hillary's going to tell her story from our addiction and recovery perspective. And I'm going to talk about evidence-based, science-based treatment strategies, the brain disease, the neurobiology. So I'll be the medical science person of it, and she'll be telling from that person's perspective of somebody in recovery.
Why this time now do we need a whole book specializing in women and addiction?
Yeah, a wonderful question. So there are books from people talking about their own substance use journeys and addiction journeys and recovery, which is great. There are also books that are medical books about addiction. They tend to be a bit more textbooky. We didn't want to do that. We wanted to create a book that's much more storytelling infused with science, because there's too much misinformation out there. We also knew that we need to tell more stories about women, and we need to tell women, make sure women know, and society, people who love women and know women and care for women, that they know that need to be more tailored treatment programs, services that are tailored to the unique needs of women, right? So while many of the things that we'll talk about, certainly in the book, my parts of the book, the science behind it, the medications, therapies, sure, many that apply are helpful to men as well, but we need far more treatment strategies and approaches and services that are tailored to women. Many more women experience trauma. Women who are mothers are often the sole primary caregivers for both children and elderly parents and relatives and loved ones. When women or mothers are caught by our system, our legal criminal justice system, they are thrown in jail and prison, and that often leads the child to go foster care, whatever. I mean, there are so many other complexities that apply uniquely to women that don't apply to most men. And then also just the reproductive journey. That's another very unique perspective of experience of women that men just don't experience. Yes, puberty, but menses, periods, the menstrual cycle, of course, with pregnancy, and then menopause, pre-menopause, post-menopause. These are all experiences that are unique to women, and when it comes to addiction, it affects the entire cycle and experience with addiction. So there are very, very, very few books out there that really address the holistic experience and unique experiences of women. And our book, we're very confident, is going to tackle all of that.
Excellent. Yeah, I know now. I mean, we've been seeing so much and talking a lot about perimenopause and alcohol. How do you see that relationship, women and perimenopause and alcohol? What's your take?
Oh, I mean, well, let's just talk about alcohol here. You know what we discovered during the pandemic? Studies have shown that alcohol consumption in general has decreased, which is great news. However, it's gone up in two populations, in women and older folks, older people. So that is problematic in many ways. Again, another reason for why we are writing this book, right? So why is alcohol? Why is it going up in women, right? And do you remember, Jana, the messages, all these mixed messages about alcohol. There was a time, and the medical and scientific community said to people, "Oh, to have a glass of wine at night, it's heart healthy. It's good for your heart." Actually, we now have data showing that no amount of alcohol has health benefits. The other, kind of misconception that's out there with alcohol is that not only that it used to be healthy, it's actually not. The other one is that alcohol, it mostly affects your liver, right? People associate alcohol with liver disease and alcoholic hepatitis, and that is true. However, I remind people, my patients and the public, that alcohol adversely affects almost every organ in your body. People forget that you can get heart failure, alcoholic cardiomyopathy. You can get severe, especially with heavy alcohol use, brain damage. Your skin, heart, lungs, kidney, you name it. Just similar to smoking, cigarettes. Cigarettes actually adversely affect or harm your whole body. Alcohol is no different. So those are, I think, key messages that we want to send out. I remind people the connection between alcohol and cancer. Alcohol increases your risk for about 7 different types of cancer, including breast cancer, colon cancer, and then again, I'm a very visual learner, so I start from top to bottom. Oral, so your mouth, your throat, larynx, pharynx, breast, stomach, esophageal, stomach, pancreas, and colon.
Colorectal cancer.
And pancreas. So all these different types of cancers, risk can go up with alcohol. Again, I don't like to tell people what they should not do. Again, my job as a trained medical professional is to provide the best possible clinical advice and medical advice based on data. But people want to have a glass of wine or a beer with friends. I mean, I have chocolate cake. Last I checked, there were no health benefits to chocolate cake. But it's all about, doing what you enjoy, but in moderation and knowing what the risks are.
Yeah. And it depends who you are and knowing if you have that risk already. For many of our listeners, they have tried and alcohol doesn't typically work for them. Yes. So I think it's important to slow it down, especially with a lot of the recent information that's come out from the government that there are no health benefits to drinking alcohol.
Correct. The scientific community has made that very clear. Most recent data, it's no amount of alcohol is safe.
That's huge.
Yes.
That is huge. So despite being an incredible social lubricant, as the expression is going around now, no amount of alcohol is moving you towards health and wellness.
No, but at the same time, I do believe in joy and happiness and pleasure. And again, remember, people use people's motivation to use, and then for those that develop an addiction, it varies, right?
Mm-hmm.
Some people smoke cigarettes because it calms their nerves. They drink alcohol to calm their nerves. They take heroin to get sleep. So it's important to understand what the motivation is,
absolutely.
and to find then safer alternatives to address their symptoms, because it's important to understand what the symptoms are. Those are real, right?
Absolutely.
People have anxiety. People have sleep problems. People have all these, and so they're but instead of self-medicating, let's maybe talk to some trained professionals and to get the proper evidence-based, safe ways to get help.
That is so important. Oh my gosh. I also want to ask, speaking so many things you've said, I'm thinking about women, buprenorphine, and methadone. If you could share how, when women, I know there's a lot of concern about safety.
Yeah.
And I often think, well, these drugs have been tested, medicines have been tested and proved safe even through pregnancy. But as you speak about that?
Oh, absolutely. I'm so glad you asked that. Yeah, a lot of women, particularly during pregnancy, unfortunately, society still tells them, oh, you need to detox. And I have to say, again, another very common, unfortunate myth is that detox, you just need to go through detox 3-5 days and you'll be better. That is so not true. Detox, particularly for pregnant women, very harmful. Detox is not treatment. And we just talked about how addiction is a chronic condition that needs chronic treatment. You would never tell somebody with diabetes, oh, I'll just give you insulin for 3 days and then you'll be good.
Yeah.
No.
Very true.
Right? Yeah, we don't do that. Somebody with high blood pressure or with asthma, we don't say, oh, just take this inhaler, I'll be able for 2 days, and then you'll be done.
But no, you still need to continue your care.
To continue treatment. Mm-hmm. We know, studies are very clear. The first line treatment for people with opioid addiction or opioid use disorder, it's medications. First line medications specifically, there are 3 FDA approved medications: methadone, buprenorphine, and naltrexone. Buprenorphine, methadone, we have the most data for safety and efficacy data, and particularly pregnancy. Detox is one of the worst things you can do, actually, because you're harming not only the woman, but also the fetus. So first line treatment for pregnant people with opioid use disorder, it's methadone or buprenorphine. We know that. Not naltrexone. It's actually agonist therapy.
So, and the fetus will be is okay with it.
So the fetus, the child may actually still develop NAS, neonatal abstinence syndrome, but we know how to treat that.
Yeah.
It's much better that they develop that and then get treatment rather than being detoxed and being actively, forcibly stopped. And it's far more dangerous, both to mom and to fetus, because relapse rates with detox alone, relapse rates are over 90%. With just detox.
Just detox.
So we know that if you just put somebody through detox 3-5 days, they are going to relapse or return to use. Most of them, the vast majority.
That is an incredible statistic.
Yes.
That actually could have gone in our next section about myths versus reality of addiction treatment, but that is really remarkable.
It can be as high. I'm not saying it's always, but it can be as high as 90%. Well, why would you do that? I mean, if a patient is telling you, no, I just don't want to be on these meds, I don't want to, but then I explore a bit further. I'm like, so tell me, why do you know what's there? And they're like, I've had patients say, doc, I want to be off of all drugs. I'm like, well, what if I told you that methadone and buprenorphine, yes, they bind the same opioid receptor as heroin, but unlike heroin, which acts really quickly, methadone and buprenorphine take hours, if not days, to reach a steady state, and then it stays bound. And that's why it's so effective at reducing those uncomfortable cravings and withdrawal symptoms. So once I explain it like that, they are like, And they know I don't have to hit them like a hammer over the head. They know, they feel better. And I'm like, well, correct me if I'm wrong. Before you came to our methadone clinic, before you started methadone, you were using how much? Like 1-2 bundles a day? That's 10 to 20 bags of hammer a day. And now that you've been methadone for like 1 month, 6 months, whatever, forget that long, even like 3-4 weeks, how much are you using now? Oh, I haven't used in 2 weeks. Or I've down to like 1 small bag. From 20 bags to 1. What does that tell you? They're like, so my job, honestly, Jana, is to be like a coach, a cheerleader, you know? I just have a few letters behind my name.
Evidence-based treatments.
Exactly.
I know your passion. Evidence-based treatments.
What it is. But I
and the best medicine we have of today.
I use their example, like, you already know, right? So I tell these stories to reduce the stigma behind these treatments. I don't even like calling them drugs. Methadone is not a drug. It's because the word drug is so, right? It's like, it causes other problems, right? It perpetuates stigma. So these are medications, just like insulin is for diabetes, just like atenolol and lisinopril are for blood pressure. Methadone, buprenorphine are medication. Naltrexone, both for alcohol and opioids. These are medications. But also there's other evidence-based therapies, counseling, harm reduction, recovery coaching, peers. All of these are evidence-based and highly effective. We just need to connect people to these treatments.
Can you share, I know we were going to talk a little bit more about myths of substance use disorders and the reality. Could you share like 3 myths and realities with us?
Yeah, and Frank, we already talked about several. Like one of them was, people with addiction they're morally weak. No, they're not. They have a chronic treatable disease. That's one myth. Another myth, methadone, buprenorphine, you're just substituting one addiction for another. No, these are chronic treatments, chronic evidence-based medications to treat a chronic disease. This other myth, alcohol is heart healthy. It's not. We've already talked about how alcohol actually it can be harmful. And this idea that, relapse or return to use means that treatment has failed. No, it doesn't, because we know that relapse or return to use is an expected reaction or response to, frankly, any chronic illness. People with asthma and high blood pressure have higher rates of like relapse than people with addiction. And then another one is, and we talked about this, that, detox, that's sufficient to get better. They're better now. And it's not, right? It's a chronic condition that needs chronic treatment. Now, does that mean a person has to be on medications for the rest of life? No, for as long as they need it. And that's a decision that should only be between the patient or the client and their helper.
And again, you are phenomenal breaking things down. I'm still stuck on the way you described the buprenorphine in the brain. Yeah. How can people listen to you and learn more? We find you.
So as you can tell, I'm a total medical nerd. I love talking about health and medicine. I'm very active on social media. I'm constantly posting videos, my own content, writing articles. So people can find me on social media, on Instagram and on TikTok at Lipi Roy ND. So that's at LIPIROY MD. They're active on LinkedIn, but really the main ways, and then on Twitter X, that's just at Lipi Roy. But if you connect with me there, and then I have a YouTube show. So if you just go to YouTube, have the app on your phone or online.
And tell us again the title of your YouTube show.
The title of my YouTube show is Health, Humor, and Harmony. And just, I think just put in Dr. Lipi Roy, LIPIROY. And then I'll, because I'm a big hockey fan, as you know, Jana, I also started part of that, another YouTube show called Health, Hockey, and Leadership. But it's all under Health, Humor, and Harmony. And I love, please subscribe for free and put in comments. I read all the comments. So yeah, these are some ways. And then as you know, as you stated kindly, I launched a company called Sita Med. It stands for Strength and Inspiration in Trauma and Addiction, using mindfulness, empathy, and delight. So if any of your wonderful listeners, they're working for a company or an organization where they could use a speaker or somebody training their staff, I would love to do that. Just reach out to me. I love talking about this.
I am so grateful for you for coming up to Canaan, Connecticut to visit with us and share your experience and knowledge. Thank you so much, Lipi.
I'm so delighted. Thank you for having me.
If you or a loved one is struggling with addiction, Mountainside can help. Call 860-365-6764 to speak with our caring treatment team.